All right, welcome everybody to this year's 7th annual Shark Tank competition hosted during Department of Medicine Grand Rounds. I will be your MC for this afternoon. My name is Tyler Anstedt. I'm an assistant professor in the Division of Hospital Medicine and I also serve as one of the associate vice chairs for quality within the Department of Medicine. Thank you everyone for being here in person today, and thank you everyone who's on Zoom. Thank you for being on Zoom as well. This is one of our favorite times of the year because we get to really focus on innovative ideas for advancing high value care. So let's dive in to where we are. So here's CME MOC credits for Grand Rounds. Feel free to scan that as we go throughout. It'll be available as a link in the chat as well. Okay, so here's our agenda. You're gonna meet the sharks. In case you didn't know, for those in the room, the sharks are the people with the shark fins on their heads. Just a little cue for you to know who they are. Giving themselves a round of applause. We'll go through finalist presentations. We'll have an update from last year's winner to show you the progress that they have made, which is substantial. And then finally, we'll have our winner announcement real time during this session. Okay, so none of our presenters, nor I don't think our sharks, not totally clear on that, have any relevant financial disclosures. Okay. So here's what we're here to do. We're here to improve the value of care that we provide in our hospitals and clinics here on this campus and with our affiliates. And what is high value care, or what is the value of care? So we think of it in this way, where we're trying to improve the quality, safety, the experience of both patients and providers, by the way, health equity, all over how much cost. And sometimes that's dollars, but sometimes it's other things. So you'll hear these elements through our finalist presentations today. So that's what we're striving to do, is improve the value of care that we provide, okay? And as a update, a little selfish plug for some of us here in the room, our very first Shark Tank winners were a group of hospital medicine residents that worked to improve PICC line insertions at University of Colorado Hospital. And I'm delighted to tell you that they received their first publication of this work just a couple months ago. So big shout out to them. Thank you. All right, so here's the sort of structure of our finalist presentation. So we have a 3-minute pitch from our finalists. They have all pre-recorded videos so we can stick to time. So you'll see their video editing and acting skills for some of them. We'll have a 4-minute Q&A with each of the sharks. And then the sharks are going to deliberate after all of the videos and the presentations and the Q&As have happened. We're going to deliberate for 10 to 15 minutes, and we'll come back and we will announce the winner. The winner receives a quality coaching from the Department of Medicine, project management from the Department of Medicine, Epic analyst support or other analytic support that might need, prioritization and high visibility through winning this coveted prize, and best of all, if you haven't seen it yet, literally a Shark Jaws trophy that will travel with them to wherever they go on their roadshow and maybe live in their clinic or in their hospital unit, wherever the winners may live, okay? Here are our Shark Tank judges. Our esteemed judges are presented before you. We have Dr. Vineet Chopra, who's our chair of medicine. Wave to everybody, or bite, or whatever you're thinking. We have Dr. C.T. Lin, professor of medicine, chief medical informatics officer here at UC Health. Dr. Jeff Glasheen. Jeff, thanks for being here. Dr. Jennifer Weiler, professor of emergency medicine. Dr. Ann Fulbrigge. And finally, Dr. Jean Kettner. So big round of applause for our sharks for being here today. And for thus, entertaining us with their ridiculous hats that we made them wear. So appreciate it, guys. Our Shark Tank finalist number 1 is Dr. Rudofker. So we're going to go to his video now. He's doing this in conjunction with Dr. Rosenberg, and their work is around improving inter-hospital transfers to cardiology services.
Hi, I'm Eric Rudofker, and I'm excited to share my project on inter-hospital transfers to cardiology services. Dr. Rosenberg is my faculty mentor, and I have no disclosures for this talk. Okay, so imagine you're on your cardiac ICU rounds, running around doing your thing, and your phone buzzes, and it's the ED. And the friendly ED doc on the other line says, hey, I have this patient who was just here with heart failure. You immediately look up the chart, see what happened, and can quickly and efficiently get a sense of this patient's needs. Now picture the same scenario, but this time it's a nurse. And he or she says, hey, that transfer's here and the family has some questions for you and I need admission orders. You may or may not have heard about this patient ahead of time and the EPIC chart is blank. According to survey data, A lot of the time, this patient will arrive more than 24 hours after accepting them, often with insufficient records, and the patient and family may have unrealistic expectations for their care. You may think, okay, well, these are issues inherent with transfers. Is this really a problem? But I'd argue that this is a group of patients we should pay attention to, because these patients use a lot of resources, and we can and should give them better outcomes. We see a ton of transfers here. Last year across the UC Health system, we received over 11,000 of them, and an alarming 8% of them died, many within 48 hours. In cardiology, a high percentage of our admissions are transfers. We work with a small number of residents, fellows, and nursing units, which makes tailoring QI interventions much easier. We have the potential and ability to care for anyone here, but to improve their care, we need to communicate more effectively and plan ahead, because transferred patients are a different population that need an individualized approach to care prior to their arrival. So far, we've done some things, but not enough. One is creating this smart phrase, which captures critical information about incoming patients. We have better ideas for what we can do next. One is our nurses are the first line of communication when accepting a patient from another hospital. We need to leverage this and use that nurse-to-nurse handoff as the initial action in a cascade of preparations with the primary team. We have some bigger and bolder ideas too, like a centralized board of patients in queue for transfer, along with their acuity status and ETA. We're taking data from transfers and performing clustering and modeling analyses that allow us to identify the highest risk transfers so that we can triage them to the appropriate level of care with the appropriate resources. So Sharks, what we need from you is first data. We've been in a months-long queue with Health Data Compass, and we don't have the capabilities that medicine does to quickly get clinically relevant data from our own EMR. And we need help rounding up our nursing leadership, working with stakeholders to implement some of our multidisciplinary communication efforts. Thanks for listening, and best of luck to the other participants.
All right, Dr. Rudofker, answer some questions.
All right.
You're in the tank.
Thank you.
I'll shout it out.
No, wait, we have Zoom. Hold on.
Okay.
It looks like it's on now.
I'll try.
Okay.
Patience charts.
First question: how would success be determined, and what are the key metrics for your success?
Yeah, great question. I think the key metrics are really going to, at least initially, around communication, focus on the people that are doing the admitting. How satisfied were you with the information that you had ahead of time? How prepared did you feel for this admission? I think you could use some other metrics such as escalations of care, like going from a floor to an ICU. I think that 48-hour mortality is another metric that we've actually seen with some of our other transfers. So, those might be bigger picture long-term metrics. But I think the focus, we just want to work with our residents and our fellows and say, how did this admission go for you?
Okay, thank you. Next question: do you think nurses will have the time to huddle to do the pre-transfer work? And also, how will the model be developed when some of the variables are not available for those outside of our system?
Yeah, great question. So in terms of modeling analyses, we're of course limited to the data that we have. Actually, a fair number of our transfers, I'm told, do come from within the UC Health system or from hospitals that do have care everywhere, which may complicate some of the analyses, but may actually introduce some potential to get other data. Will nurses have time? I hate to suggest something that puts another thing on someone else's plate, right? This is really critical. I mean, often I'm getting a call, or my colleagues were getting called from nurses. They already know that the patient has a central line and is on these medications. From our standpoint, maybe we can synthesize that and say, hey, maybe this isn't the appropriate level of care. I think there are really important details of communication that physicians are really bad at telling other physicians, that nurses are really good at telling other nurses, that we need to be looped into that.
Final question: how would the proposed approach fit into existing transfer, or is this only for direct transfers or those that come through the ED?
Yeah, so the focus of this and other work that I've done and others is really transfers that come from another hospital. I think we've been able to show that patients that arrive from another hospital as opposed to the ED or a direct admission have a different set of characteristics, different set of needs. That's really the target population. And for this project specific to cardiology, which allows us to focus in on a smaller number of patients, smaller number of nurses, fellows, residents, with the potential to scale to other units or other services.
Finally, this project is very dependent upon data, and if you're unable to get the data you need, will you still be able to do a version of this project?
Yeah, that's a great question, and I've thought a lot about that. Dr. Rosenberg is the data expert, and has some creative ideas over how we can use insights from clinical parameters from these patients. But I think, as I said, we really want to focus on the people that are doing the work up front, the nurses on the front line, the residents, the fellows doing the admissions themselves. And so I think we don't really need background data to start approaching nurses and residents and fellows and saying, hey, how can we make this process better of admitting a patient from another hospital?
Okay, thank you very much.
Thank you, Dr. Rudofker.
Thanks.
Okay, next we have Drs. Choksi and Greca from Endocrinology. Here's their video.
Good afternoon. Today, we are pitching the idea of endocrine office hours for community providers. Access to endocrine remains low. We currently receive about 1,300 consults per month and see about 350 per month. New patient no-shows and late cancellations are typically higher than that of return visits, and many patients travel long distances and oftentimes wait several months in order to see the specialist, which is not only frustrating, but can lead to delay in care. At UC Health, we have e-consults that are available to our providers. This is a direct provider-to-provider consultation. Several specialties answer e-consults, and endocrine currently has the highest volume. In the last year, we answered about 1,000 plus e-consults. These are geared towards low or moderate complexity patient questions, and in certain cases can also expedite the workup. But e-consults are not available to our community providers. Our community providers, they have access to DocLine, which is a synchronous consult, and it is the inpatient or the rounding attending is the only one who's answering these calls and can oftentimes be disruptive. The care provided is also rushed and is oftentimes felt to be suboptimal. In order to fill this gap, we are pitching the idea of an asynchronous consult or an A-consult.
So we propose a referral and scheduling process which will include the whole division, where the 8 consults will be scheduled based on provider interest groups such as pituitary, thyroid, diabetes, obesity, etc. The 1-hour block during the regular scheduled clinic sessions will be converted to 4 8 consults. The specialist will document the full case review and recommendations. 8 consults will be billed to health insurance, and the provider will get RVUs per every 8 consult. The outcomes that we will be including are they improve our new patient access by 50%. We will increase usage of the 8 consults to represent 10% of all the consults received to the endocrinology division, and we would improve patient and provider satisfaction. In the benefits, we are trying to increase the availability to answer the new consults. We will try to improve provider to patient satisfaction. It will be cost effective and will be improving our relationship with our community providers. With the support that this project will receive, we will be utilized on coaching, data prioritization, analytics development, and increased visibility in the UC Health and Department of Medicine. This whole support will be used to create the 8 consult process and scheduling and survey the physicians.
Right. Doctors Choksi and Greca, you're in the Shark Tank.
So awesome presentation, wonderful idea. A couple of questions that the team had for you. Number one is you talk about a 50% increase in consultations. Is that because you'll be counting these new A consults as new consults, or will this 50% be the consults that are seen in the traditional manner?
So that would be both. We would increase the number of new patient referrals that are actually seen or addressed by an endocrinologist, either asynchronously or in-person visits. And at the same time, if we are able to take away some of the low complex or low to moderate complexity patients and do it as an asynchronous consult, we anticipate getting more patients into our clinic as well.
Got it. And you had mentioned the e-consult program here. How does this relate to the e-consult program? I recognize that that's currently a little bit different than what you're talking about, but are there discussions around the e-consultation process extending to community partners as well? And would this be duplicative?
Right, we're currently doing the e-consults, which we are trying to respond to those e-consults within 72 hours. The A-consult, we will try to answer within 2 weeks. So it's going to be a little bit of a difference, but we are getting great success here at UC Health and using that as a pilot program for this and extending to the community providers.
And you had talked a little bit about some of the benefits of this, and one was that this would be cost effective. Can you speak a little bit about what you mean when you say cost effective, and how would you measure that?
Well, one of the main things is we're losing a lot of patients that are not getting scheduled on time because they end up getting scheduled with other community providers. So that's going to be more revenue for our clinic. And then we are going to also try to build insurance for that, like we're doing for e-consults. So this idea is to build all the A-consults to insurance, which would equal 1 new patient for 4 A-consults.
So I guess a follow-up on that then, is that financially a better model than the current model, or are you saying it's essentially the same?
It's better because we're going to provide more care to more patients. So instead of losing about 800 to 900 new referrals, we're going to be able to answer all of them and get more new patients in person to our clinic.
Awesome. And you talked a little bit about...
Sorry, if I can
add,
also add that the new patients that we will bring into our clinic will also be the ones who are higher complexity patients compared to the lower complexity where we won't be able to bill as high a level of billing.
So it'll be more patients and potentially patients that have a higher level of complexity.
Yeah.
Excellent. And then you talked a little bit about the relationship with the community providers being improved. Do you intend to measure that? And if so, how would that measurement look?
Yes, we do intend to measure it because we do feel like community providers are oftentimes very frustrated when their patients cannot get in to see specialists in a timely manner. So one of the things that we would like to measure is how often would they be utilizing this asynchronous consult, and how did it improve their care with their patient as well as communication with their patients? Because they get it at their end, and by the time the patient comes to see the specialist, we get it too. You know, the first thing is like, I waited several months for this appointment. Yeah. So we anticipate that both the referring provider as well as the specialist will benefit from this. In addition, the patient will be the one who stands to gain the most here. Lastly, we do feel like some of the workup can be completed by the primary care provider, so involving them more in the care of their own patients before they come to see the specialist.
Excellent. Thank you for your presentation. That was wonderful.
Thank you very much. All right. Our next finalists are Dr. Haussmann and Dr. Meyer, both internal medicine residents here in our training program.
We are excited to tell you about our project to improve testing and diagnosis of asthma. We presented last year at Shark Tank and listened to your valuable feedback. We have scaled the project to include a new generation of interns and are excited with your support to scale from the Denver health system into the UC health system. Asthma affects 8% of all Americans. In Denver County alone, that represents 60,000 patients. International and national asthma guidelines recommend annual pulmonary function testing, but we are nowhere near meeting that benchmark for these patients. In fact, in our analysis in 2020 of the Denver Health Asthma Registry, only 8.7% of their patients had ever had objective pulmonary functions. This lack of testing is harming patients. One JAMA study showed that up to a third of patients with, quote, chart asthma don't actually have asthma on objective testing, and 2% actually have a severe cardiac or pulmonary disease that we've missed. Furthermore, the lack of testing costs health systems dollars, particularly as Symbicort is now the first-line treatment for these patients.
Here is an example of the impact of objective testing. This patient is 43 with 3 years history of asthma. She came to clinic with worsening shortness of breath. She never previously had objective function testing. Her PFT showed a restrictive pattern, which is not consistent with asthma. Alternative diagnoses were pursued with a CT-ILD being ordered, which showed interstitial lung disease. She was taken off her previous ICS-LABA without worsening of her symptoms, and she is currently being worked up for the cause of her interstitial lung disease. Last year, we presented our data regarding barriers to getting tested. Providers had perceived barriers that patients would not be able to get testing completed, and they thought that testing might not change management. However, 89% of patients who had orders for objective testing completed it, and our group bridged the knowledge gap among providers through a series of educational sessions, which have already reached approximately 150 providers. As you can see in the chart here, rates of pulmonary function testing ordering post-education are already higher. Imagine the impact that we can make with an EPIC intervention and your support. Based on our survey of Denver health providers, we know that over 90% are looking for an EPIC intervention to improve asthma care. Based on this and discussions with stakeholders, we believe a healthcare maintenance topic is the best option. It is easily visible in all outpatient visits and is patient-facing to empower patients to bring it up as well during visits. Since we presented to you last year, we have gained the approval of IM and FM to move forward with the healthcare maintenance topic, but we need your support to build it. This could impact more than 16,000 patients on initial rollout.
To build on our momentum in the Denver health system, we are hoping to expand to 4 UC Health clinic sites that house family medicine and internal medicine residents. Based on our preliminary analysis of these sites, rates of objective testing for asthma there are currently very low at only 21%. Our poor rates of testing are very fixable. We just need to bridge the ordering gap. We believe that is achievable through our ongoing educational efforts and with the implementation of an EPIC intervention. These are well underway. We just need your support to get across the finish line and expand into the UC health system.
Right. Forgot to also introduce Drs. Mugdal and Murray, who are also on this team, and they're now in the tank.
Wonderful. Thank you for your presentation and for your focus on something in the ambulatory setting. Talk about the approach to behavior change. You know, we often approach QI problems with a technical solution, an EPIC build in this case, missing that the behavioral change and using that tool and actually changing ordering behavior is the hardest part. How would you approach getting people to actually change their behavior?
Yeah, so press the button, it should work now. There's a few different ways that we've tried to approach this, but I would say first and foremost, we've been holding education sessions. And I think one of the things is that there was a lot of provider perceived barriers. So thinking that patients wouldn't be able to get to a testing site, that they couldn't afford the copay, all of these things that turned out to actually not pan out to be true. We saw that over 90% of people who had testing ordered for them actually were able to complete testing. So first, presenting that information to providers has led to some sort of a cognitive shift. And then the second piece that we really gained from surveying all of the providers was that they were not sure about how PFTs could change their management. And so we've been delivering education sessions as well. And so now that people are kind of understanding what do we want to order when we get PFTs, how will this change our inhaler therapies or our potential workup of other disease, there seems to already be an improvement in getting PFTs orders, but people want a reminder because the reality is that there's so many things to address in a single primary care visit that a lot of times asthma falls to the wayside. And so that's what we found from asking the providers is they want a visual reminder, hey, remind me to order these PFTs because at the next visit, we can talk about this and we can see if we need to make a change.
And just checking, those surveys were done at Denver Health or at university or both?
So we've given educational talks to the residents, so who work both at the university and at Denver Health. So we've given a talk to family medicine residents, and I think internal medicine's at Denver Health, but obviously hoping to expand that to residents at the university.
I think, Dr. Kuttner, the survey was conducted at Denver Health, but with your support, I think our intentions are to expand that survey into the UCH system.
Great, thanks for clarifying, Dr. Hurley. Wondering if there have been any preliminary discussions at all with the UC Health EPIC team on the feasibility of changing the healthcare module.
I mean, we haven't had formal discussions yet, but the feedback last year was that there was a few different people we were put in touch with. Like these were the people that once we get it implemented at Denver Health, these are the people who would be able to help us build it at the university. So we really would need the support to do that. But it sounds like there are some people that have been identified that would be able to help us build this.
Terrific. Thank you. And you mentioned internal medicine and family medicine. Why limit to focusing only there?
So I think that at least the reason that we've been presenting to internal medicine and family medicine is because this has really been a resident run and conceived project. And so we wanted to start by focusing with the residents in family medicine and internal medicine. But our initial survey was at sites that included family medicine, internal medicine residents, but also we asked the attending provider. So it was kind of encompassed more than just the resident perspective.
Right, and sneak in the last question. Any thoughts on the impact of access to outpatient PFTs if suddenly there's all these reminders to get them done?
Yeah, so we've already built ties at Denver Health, but at Denver Health, they have a lot of availability. They actually just outfitted their PFT lab to double the amount of PFT testing. And so they were really in support of this project. And we worked with them when we kind of initially conceived it. And we did a root cause analysis with the PFT lab coordinators, and they have the availability and they're excited because it will bring revenue to Denver Health as well. And they have a lot of empty slots.
Thank you
so much. Okay, our next finalists are Drs. Longino and Gill, who are talking to us about Ultra HR. Here's what that means.
Hi there, Sharks. My name is August Longino, and today I'm here to talk to you about our project Ultra HF, Ultrasound to Reduce Admissions for Heart Failure. It was Bertrand Russell, the famous Nobel laureate, who first told us that the mark of a civilized human is the ability to look upon a column of numbers and weep. Well, today, I'd like to show you a column of numbers that I think would bring any civilized hospital administrator or provider to tears. The first of these is 1 million, the number of new heart failure diagnoses in the United States every year. The next, 3 million, the number of heart failure readmissions we see over that same time period. 29%, the one-year mortality after a patient's first heart failure admission. $19,000. The cost of a single heart failure admission in this country. You put those numbers together, you get to this number, $70 billion US. That's the estimated total cost of heart failure care in the year 2030. But why is this happening when we know what to do for these patients? Multiple studies have shown that if we can reach full decongestion by the time of discharge, if we can get these patients dry, we can decrease their rate of readmission, we can decrease their mortality, we can decrease our hospital costs, and most importantly, we can increase the patient quality of life. The question is, how do you know when your patient is dry? Well, you could do a physical exam, but we know that's an unreliable metric that varies widely between providers. You could also do a right heart cath. This is an expensive procedure, it's invasive to the patient, and it's time consuming. It's not something you can do every day. So we need something new. It's for that reason that in 2020, a group of Canadian physicians invented the Venous Excess Ultrasound Exam, or VEXUS exam, a comprehensive 4-point ultrasound exam of venous congestion in the major vessels. So it takes into account the IVC, the hepatic veins, portal veins, and renal vasculature. And we recently validated it at our center against right heart catheterization. And what we found was that this technique is a cheap, fast, non-invasive predictor of diuretic tolerance. We could get them drier. Here's what we want to do. Heart failure patients who are admitted to the CICU will undergo a VEXUS on admission, and then the day before the team thinks that they're going to discharge. The results from that study will be made available to the primary team to inform their treatment decisions around things like diuresis. We ask from you QI coaching and program design, and we would ask that you help us raise awareness of our protocol to help get buy-in from other physicians, and assistance with data collection and analysis. 2024, we hope to reduce heart failure readmissions by 10%, as well as reducing right heart catheterization by the same amount. Beyond that, we are looking forward to training a generation of new physicians to interpret and perform this novel technique. All of this is in service of doing better for our patients.
All right, welcome to the tank. We'll see if our sharks are civilized.
Definitely with this headband on, we are. My first few questions are around logistics. Can you talk a little bit about the training? Do we have providers or technicians who are capable of doing this examination, or will there be a required training element?
Yeah, I'm so happy you asked. I think that's extremely important. So whenever we want to introduce a new technique, especially something that's as variable between providers as ultrasound, it's very important that we have uniform training. And so we've actually just gone through an about 6-month-long project in which we have trained up a whole group of young Vexaseers. So among them, medical students, emergency medicine residents, and internal medicine residents, all of whom started with just the sort of basic ultrasonography practice that's taught in our residency programs. And they managed to generate a really impressive portfolio of images that were validated by the designers of the VEXA score. And that work was actually just published in Critical Care, which is very exciting for us. When you think about kind of implementing this at scale, beyond our handful of residents, the ultrasonographers that would be doing this technique, we think we're probably going to add it on to the routine echo order that people get. The ultrasonographers that would be doing this have vastly more experience than the residents that we train to do these images, that were able to produce exams that were of sufficiently high quality to pass muster of the people that designed the study. And 1 second.
Thanks for that question. Just 2 comments to add to that. So we're in the middle of looking at inter and inter-observer variability amongst our operators currently. And then I also want to mention that, our current exam done by the Echo Lab to look at volume status, that includes 40 clips, typically, LV size, RV size and function, PA systolic pressure, and IVC. The IVC is not useful in patients that are intubated. That's another group of patients that we're investigating currently.
And
so can you clarify? So this is very helpful. But we have technicians that are trained or can be in a provider workforce that's getting trained or can be. My follow-up question was around access to equipment. Obviously, those 2 groups use different types of equipment. So can you clarify, is your plan to have 2 cohorts then as part of your intervention, or do you plan to focus on one or the other?
So the technique that we use can be completed with basically any of the Philips equipment at the U, and then we've been using the Mindrays over at Denver Health. So the exam can be done with basically any ultrasound as long as you can connect an EKG lead to it. Depending on the level of funding and support that we receive, that will, I think, kind of determine the machines that we're able to use. But as of now, the current plan is just to use the Philips machines that are present in the CICU, so that this can be a very democratic sort of undertaking where, our resident can go do this, an ultrasonographer can go do this. Ultimately, I think this will be really fun and interesting to see if this is something that people follow daily, in the same way that we do blood pressures or reviewing the tele.
Can you talk a little bit about why focus only on the CICU? Obviously, these patients are in other acute care settings. Why only the focus there?
Of course, we want to be wary of flying too close to the sun and having too grand an ambition, especially for a group that doesn't specifically provide funding, for example. So we wanted to have sort of a pilot project where we were able to have a highly controlled environment with people who are spending a lot of their time thinking about heart failure and collecting a lot of those outcomes, sort of as proof of concept. Ultimately, I think this is something that's going to be really helpful, on the wards and in the community. I think this is just the tip of the iceberg.
Great, thank you so much.
Thank you very much. All right, next up, we have Doctors Runkel and Tietz speaking about geriatric consultation in the emergency department.
Hey, this is admissions returning a page.
Hey, this is the ED. I got an admission for you. I have a 98-year-old female with multiple falls this month, and she lives alone. I just don't feel great about sending her home tonight.
Man, it would be great if we could send her home, given the morbidity and mortality associated with hospitalizations in older adults.
Yeah, these situations are always really tough. I think we could just obs her for the night.
All right, sounds good. We'll find her a bed.
Hi, my name is Kate Runkel, and I'm a current geriatrics fellow and will soon be faculty in the geriatrics division of internal medicine. This is a project to start a geriatrics consultation service in the ED. The CDC reported that 20% of patients 75 and older were hospitalized in 2018, and 7% of those were hospitalized 2 or more times. We know that hospitalization has high morbidity and mortality in this population. Just for a reference, this is our seniors clinic data from 2022. We have about 4,400 patients and about 1,800 ED visits total in 2022, with the majority of those being seen at the university. We had about 500 admissions, and a majority of those were at the university. About 50% of all the visits occurred Monday through Friday, 8 to 5. Our goal is to reduce the number of seniors admissions by 10% in 1 year. This program is slated to launch in September 2023. Of course, we will continue the PDSA cycle through that time, and in September 2024, we hope to evaluate effectiveness of this project. We expect that this consult will be available Monday through Friday, 8 to 5, with a geriatrician or a geriatrics trained APP. The current plan is to have an auto consult for any seniors clinic patient that walks into the ED. The provider would get a notification and evaluate that patient. There's 3 areas that we're expected to intervene on. 1, if they're going to the ICU, we would conduct goals of care discussions if we can capture that patient quickly when they're seen in the emergency department. 2, if they are possible admission and we can re-triage them home, we can set them up with necessary supports and close follow-up with our acute care clinic. 3, if the expectation is to discharge home, we would set them up with PCP follow-up and order any necessary interventions. Multiple studies have demonstrated that geriatric evaluation in the emergency department has a reduction in admissions, reduction in revisits to the ED, even reduction in nursing home admissions. Research also shows a reduction in functional decline due to care coordination conducted by geriatricians. Cost savings has been evaluated with similar projects demonstrating thousands of dollars saved by hospital systems, and certainly cost savings for the patient if they're not admitted. Another study actually evaluated ED provider satisfaction, and one provider was quoted as saying, "This is by far and away one of the best interventions for patients we've introduced in years." My ask for this project is support and quality coaching and how to make this project better. Visibility will be key. And certainly in order to conduct a successful PDSA cycle, we will need assistance with data collection and data analysis. Here's my many references that I included in my proposal to you, highlighting that these programs work in other hospitals. They show good patient satisfaction, as well as reduction in cost overall for hospital systems. Thank you for listening to my proposal.
All right, you're in the tank.
So thank you very much for that presentation. Very interesting. Just to clarify the numbers, what is the percentage of geriatric admissions to UCH that are actually seniors clinic patients? Do we know?
Of all senior patients in general versus seniors clinic specific, I don't know if I know the exact answer to that, but hopefully this project would help us get that data.
Okay. But also, wasn't there a prior ED-based Geri consult service in the past? And if yes, how does that differ from this service? And why didn't that service continue? And are there data from the prior initiative that would inform what we need to do differently this time?
Yeah, definitely. So that project was started just before 2020, and the provider who started it left the institution. So it was a single provider that was kind of doing it amongst her other jobs. It was Scotty Church, for those of you who know her. So she was like the fellowship director. So she was being consulted only when someone had a concern and reached out, versus we're hopefully trying to consult on everybody of our patients. And mostly it stopped because COVID happened and Scotty left.
And just a logistical issue, but what happens after hours, after our admissions? Are you worried that the auto consult for all senior patients will also have a process issue with clogging up the flow of patients in the ED? And is there a way to think about targeting this better in a way that will be efficient?
Yeah, great question. The good news was the data showed that about at least 50% of our patients are seen in that Monday through Friday, 8 to 5. We've talked a lot with our ED colleagues about this and whether or not this is feasible to see if they come in at 2 a.m., is it reasonable to keep them over? And so they feel like that is absolutely worth the cost of, if we can save an admission, then that's a worthwhile venture. So we are going to have that as a qualifying option in the consult so that they can essentially obs the patient in the ED for the consult to be seen by 8 a.m. the next day. The goal would not be to keep somebody like Friday night to Monday morning, but more that those midnight hours, they could come by in the morning.
And to just clarify, it's not a required consult, so we would be notified, but like we don't want people holding people in the emergency department who can go home or should get admitted just to see us. But if they feel like they're on the borderline and waiting 4 hours till we're there in the morning is helpful, then that's an option, but it's an automatic notification to us, not an automatic required consult.
Great. So this is an operational change that involves kind of building a consult service, and providers may lose money or need support to do this work. Have you had some conversations about the commitment for resources to do this? And is there any interest from the providers to serve in this capacity?
Yes. So the main funding source is actually going to come from Primary Care First, which is a payment model in the outpatient setting that does prioritize saving admissions. And so that is initially where the funding is going to come from. Of course, the point of the project would be to gather data and see how much money we're saving, which has been demonstrated in other projects similarly, that this is actually a huge cost saving measure. But the upfront cost is going to be covered by Primary Care First through the seniors clinic.
And when you look at the outcome measures, are you looking at inpatient stays and observations and stratifying by that? And are there any other outcome measures you might want to look at, like length of stay or anything else that might be important to take a look at?
Yes, we have a whole data spreadsheet of data that we're going to collect. Fortunately, from our ED colleagues, we have the ED perspective in terms of revisits to the ED, where they go when they're admitted, lots of data points. And then we, of course, have the data perspective from the outpatient sector.
Thank you very much.
Thank you.
All right, we're now going to ask our sharks to swim out of here and go to their deliberation tank, holding tank. I'll give them my mic. I'll have choose. I was really hoping they would actually sort of swim out of here, but can't win them all. Okay, so while our sharks are deliberating, I would like to introduce you to our last year's Shark Tank winners. We're going to provide you an update on what they've been doing with their glorious winnings over this last year, including carrying their trophy around.
That stayed in the ID clinic for 2 years, so proud about that. So here, just talking about our project and what we've been up to this year. Quick background, around 10 million patients are immunosuppressed in America based on a 2019 commercial insurance studies, which most, unlike normal like HIV/AIDS or other innate immunosuppressions, with iatrogenic ones, we have the advantage that we have some time to choose and prepare for it, in which vaccination plays a role importantly, as I'm a transplant ID doctor and we do this with all our transplant patients. However, there's many other immunosuppressed patients that are not transplant patients. Here in our healthcare system, 18,000 patients in the rheumatology clinic, at least 80% of them on immunosuppression, around 5,000 in the neuroimmunology clinic, most of them in immunosuppression. And then if you go to hematology, oncology, derm, gastroenterology, and peds, the patients keep coming up and up. However, the challenge of vaccinating these patients is first the reluctancy to vaccinate from physicians due to the concerns of the efficacy and vaccine safety in this special population, that there's every year new treatments, new immunosuppressants, which make, again, the vaccine efficacy uncertain. And then there's not much standardized recommendations. Up to recently, the CDC didn't really have a table. That changed about a year ago. But before that, it was most based on case control studies and small randomized trials. And then the biggest concern, or one of the biggest problems we faced, is the difficulty obtaining the vaccines from both a physical place to where to get it, and then insurance, because just the example of a young patient wouldn't qualify for Shingrix alone based on age. The immunosuppression and the insurance might be a different consideration. And then infections themselves in MS cause relapse, so we want to prevent infections as much as we can. Here, looking at our data in a hospital, since this project started on patients with multiple sclerosis and the neuroimmunology clinic, we were looking specifically at those. So we identified 2,340 patients on anti-CD20 therapies, ocrelizumab, rituximab, that we're seeing in the neuroimmunology clinic with an MS diagnosis. From these patients here, we have the percentages of how many vaccines for each vaccine they have got in the previous years. As you see, COVID was the one that was most commonly given, up to 43%, not surprisingly taking into account the pandemic. But here is where I want to put our attention in hepatitis B. Hepatitis B can lead to acute fulminant hepatitis in people that are on anti-CD20 therapies, being a really easy thing to prevent with vaccination and a really severe thing if we don't prevent it. But if we go here, only 9% of these 2,340 patients were immune against hepatitis B, only 200 patients, which is honestly a really low number and was concerning to us. And here, this is looking at from another perspective. These are the charts where the health maintenance, I'm sure everybody has seen it when you open an encounter, you see, it reminds you like for diabetic people's A1C and other stuff. So only 4 of these patients were flagging that they needed hepatitis B. And I already said that only 9% were actually vaccinated. So the chart was failing to identify around 90 to 80 something % of patients that required and would benefit from a hepatitis B vaccine. And this is where we wanted to impact our change.
All right, so our project aim was fourfold. We wanted to start by creating guidelines for our providers on what vaccines their patients should get, especially in people in the neurology clinic, for example. They don't have a background in vaccination, don't know what they should be ordering for their patients. The second step we wanted to create was an EPIC workflow to allow providers to easily see what vaccines their patients should get without having to go back to our guidelines. The third step was the actual giving of the vaccines. How can we make this easy for our patients to get and get quickly? And then finally, we wanted to collect and analyze data to see if our intervention actually helped. So before we actually presented last year at Shark Tank, we had created our guidelines, a very dense chart, but sort of applicable to the neuroimmunology patients in particular, with notes about different types of immunotherapy and timing of vaccines, meant to be sort of a comprehensive guide, but not something you go to readily in the clinic. So that was step 1. Step 2 was to create the EPIC workflow, and this was to simplify things so you don't have to go back to that complicated guide. And with the help of the health maintenance group, we created a modifier that goes into the health maintenance module, and it's called long-term use of immunosuppressive therapy. And basically you add that, and then when you refresh the chart, it pops up with the vaccines they should be getting. So hopefully those flags that weren't triggering except on 4 of our patients will start triggering for everybody. And then I have listed here the vaccines that get populated through this. And this is sort of the ones that are going to be most applicable to every patient, not including childhood vaccines, really the ones that our adult patients should be getting. Then the final step, which was the most complicated and challenging step, was getting the vaccines available to our patients. So when we presented last year at Shark Tank, we actually heard rumblings that there was some work to get vaccines available in our pharmacy as a centralized location. And we were very optimistic we could just piggyback on that. But unfortunately, that is a long project that seems like it's either never going to happen or not anytime soon for a lot of reasons, insurance, staffing. So we sort of met a hard stop there. And then we moved on and said, well, maybe for the time being, can we try to get vaccines in our MS clinic as a starting point? And everyone was on board with trying that, but we learned that the Pyxis machine that we have that keeps the vaccines is not big enough. And we could get a bigger one, which we'd have to order, but it doesn't fit in the room that we have in MS clinic for the Pyxis, and we don't have another room that has badge access. So we'd have to rearrange the entire clinic and order the machine. And it was in the process, but again, taking a very long time, and we wanted to move more quickly. So the final option was sending patients somewhere else to get their vaccines. And we were very grateful to the ID clinic where they carry all these vaccines and vaccinate patients who are traveling, transplant patients. And we worked with them and created sort of a workflow for MS patients. So this is how we settled. And we basically created this workflow, and one of our medical students helped us with this informational material for our providers. And what we do is the neurology provider or the MA in clinic will now add the modifier to the chart, refresh the chart, see which vaccines the patient needs. And then we have an order set in MS clinic where you sort of order medications, scans. At the bottom, there's a vaccine set that I have listed down here in the bottom. Sorry, it's a little bit small, but basically has all the vaccines that you might need and the timing of them that we think is appropriate. So for expedited vaccination before starting a therapy, we have the 2 vaccine series sort of close together. And then we just send a haiku message to the ID MAs and say, we have a patient coming upstairs needing vaccines, and they go upstairs and get their vaccines the same day. And we finally, as of a week and a half ago, got our first patient through this process, which we're very excited about. Thank you. This was a patient who was starting ocrelizumab and got all of her vaccines and will go back for her second visit to get the 2 series vaccines and not have any delays to getting ocrelizumab. So next steps are just to sort of continue to remind the neurology providers about this brand new system to get more patients through it. And then we want to look at how we're doing. So we want to actually, the data that we pull it again at some regular interval and see, are those numbers going up like we hope? And then I think big picture, we solved the MS clinic problem for now, but this is obviously a much bigger problem. And as wonderful as the ID clinic MAs are in helping us, they can't accommodate everybody. And so I think if we can show benefit, then we can advocate to really revisit the idea of pharmacy or some sort of centralized location. We have a lot of thank yous. I think we're probably out of time, but just thank you to everyone, the Shark Tank competition, the whole Quality and Patient Safety Committee, Brian Montague and the Health Maintenance EPIC team for getting the modifier together, the ID clinic, and then some of our partners in neuroimmunology and rheumatology. Thank you. Oh, and I think we have 5 minutes for questions. There we go. Mm-hmm.
No, now it works. So you mentioned that this is, you're right, still a lot of patients who need access to this, and especially in other clinics like rheumatology, oncology, have I assume the same problem. Have you talked to them about what they're doing, and is the goal for them to backpack onto this, or?
Yeah, and that's actually how we first got introduced to the Shark Tank competition as an option, was speaking to the rheumatology clinic about their practice. And basically the answer was, we know we need to do this, but right now we tell patients to go to their PCP, to go to a pharmacy. There isn't a system in place. I think really the only system in place is an ID clinic for transplant patients. But otherwise we sort of just tell people, you need Shingrix, go figure it out. And often that's a big challenge. So I think, yeah, ideally it would expand. Like I said, I think the pathway we created is not capable of accommodating everybody. It was sort of our fix for the short term, but ultimately it needs to be available to everybody.
The workflow in Epic, it's open to anybody. Like if you do the healthcare modifier, you can change that. Because even in my own transplant ID clinic, I've done it just so it flags them and I can order them easier. So that part is set for any clinic. The problem would be we're getting the vaccines, and that's like what we have to keep working on.
One thing that we see is with Shingrix and Tdap that it's not paid for if we give it in our clinic versus through a pharmacy. Did you guys have any trouble with like copays for patients if they're getting it in ID versus elsewhere?
So I know specifically for Medicare patients, that's the big challenge. And I think in the MS clinic world, at least, the challenge we've had are younger patients not being able to get it. So I think the majority of patients will put through the pathway, won't have that challenge. But yes, that is one. I think on our sort of educational guide for the providers, there's an asterisk that says for Medicare patients getting Shingrix, they need to go to a pharmacy.
What we do also, because we do vaccinate 18-year-olds that are going to get kidney transplant with Shingrix, is if they're Medicare, they get most of their vaccines in the clinic, and we have our own pharmacy like outside of the clinic. So they get 2 steps to get the second, like the Shingrix vaccines.
This is more a comment. Thank you so much for this work. I do most of my work in vaccines, and so this is great to hear you guys working on this. But I just want to clarify the Medicare issue, because Medicare Part D vaccines, like Shingrix, does have to be delivered in a pharmacy. Mm-hmm. But as a result of the Inflation Reduction Act, there no longer is a copay for patients. So I want you all to know that. That's as of January 1. Patients with Medicare Part D shouldn't have to pay anything for their vaccines, but you're right, they still have to go to a pharmacy. So I think really encouraging UCH pharmacies to become vaccine deliverers is key to your project.
Yes, definitely. Thank you. Mm-hmm.
So I think a related question is not related exactly to your project, but with regard to patient apprehension to getting on particular vaccines. And particularly Shingrix, I have a question about that. I find a lot of patients that are worried about side effects and so forth. And do you have any ideas or projects in mind to help with that?
Not big projects, although anecdotally, I had a conversation about this with a patient last week who's starting an immunotherapy. And at least as someone who's trained in neuroimmunology and neuroinfectious diseases, I was able to tell the patient, I have seen so many VZV complications in immunosuppressed patients. I've seen VZV meningitis, encephalitis, myelitis, and I haven't seen vaccine complications. They can happen, but I think the risk of not getting it is higher. And so that's what I said, but I think I haven't thought about it in a bigger project.
Yeah, we do face that a lot, since especially we're vaccinating younger patients that are not really that excited to get vaccines. it becomes a conversation of explaining what the immunosuppression is going to do and like how much they're not going to be, basically putting in lay terms that you're not going to be like anybody else, and even a cold could be really bad for you. And that kind of opens patients' minds. For Shingrix, I do tell them like takes a little bit of Tylenol, even liver transplants, like take 1 dose of Tylenol, you'll be fine, and that will help ameliorate the symptoms. But it's curious because sometimes like people think that Shingrix is to prevent shingles, and they don't know that if they have got it, it will help them to not get it again. Because many of my patients, after I told them that, they were like, "Oh, really? I got shingles 5 years ago. Like that will be great to not have it again." So again, it's like importance of going and talking back to the patient about it.
I also wonder if it's an official workflow that sort of pops up for everyone, if it will make it seem like less of an obscure thing that's not officially recommended, if that might make people feel more comfortable that's sort of our standard of care. Okay, I think that's all the time we have. Thank you.
All right, welcome back to our judges. Still not swimming like I've asked them to, but that's okay. All right, we've got a little built-in suspense here as we update our slides with the winner. We do have a winner. And our winner is blank screen. And just a reminder, here's what the winner gets, by the way. They get that trophy. They get coaching from us. It's going to be great. And the winner is, all right, Doctors Runkel and Tietz on geriatric consultation service in the emergency department. So we'll ask them to come up, accept their trophy. We're not going to force you to speak, but we will take a picture. Stay there. Oh. MC, photographer, I really do it all. You're welcome. Okay. And then thank you to everyone for being here. We strongly appreciate it. What's up? So why they won? Yeah, the reasoning behind they won. Why you all chose the geriatrics team? Don't all speak at once. Dr. Chopra?
I was looking at me all of a sudden.
Because you haven't spoken yet.
Yeah. Well, so question. First, I want to say this was a very difficult decision. So congratulations to everyone who presented today. We had a lot of conversations. The difference between the top score and the bottom score was less than 1 point. So you guys should know that. This was pretty tight. We thought this had the greatest odds of success in terms of the magnitude of the problem, the challenges with these patient populations. We thought the fact that the evidence existed to do this outside of this realm was compelling because there's a blueprint to moving it forward. We also thought, and we're impressed by how you thought about after hours, because I think that was the big weakness with this, and also thinking about ED length of stay. So you'd already done a lot of the groundwork in thinking about feasibility, implementation, and we thought this was the project that would likely have the greatest impact for those patients. So congratulations.
And just for those other finalists that did not win, 1, you should count yourself as finalists. 2, you're going to get detailed feedback from us, from the Department of Medicine quality team, to say what it is that the Sharks also wanted you to emphasize in some of your presentations and your projects. So you get helpful feedback as well. We're always available as a Department of Medicine quality and safety team to help you implement projects along the way. So don't think that you're losers in this thing. You just weren't eaten by the sharks. So again, thank you so much to everybody. One last video clip. And thank you so much, everybody.